Not many people, it looks like, use this technology, but we will review it. So there are a couple different kinds of ablation procedures. We're going to talk about radiofrequency ablation and microwave ablation. And there are some differences between the two techniques, although the devices can look very similar. So essentially, you have a long probe. This can be placed by open technique. It can be used laparoscopically. It can be used by interventional radiologists and cardiologists. So usually we use this in conjunction with some kind of an imaging, whether it's intraoperative ultrasound is the most frequent. Going back to the same principles, which you heard about during monopolar energy and all radiofrequency energy, we are still using electricity to create a tissue effect. So our probe is going to have energy going down it, and around the tip of the probe, we are going to get a tissue effect from the ionic proteins vibrating back and forth and creating heat. Now, what's different about this is instead of using the tip, the surface area of your electrode to create effect, you are using the length of this exposed probe. And so when you're thinking about your tissue effect, you have kind of your near field and far field effects that you get in order to get tissue destruction. So the red area that you see is that active dispersal of your current into the tissues, but because of heat, you can get a second thermal effect beyond where the current is actually going. So there's that active and passive effect in the tissues. And depending on how much conductivity your tissue has, so if there's a lot of water in it, obviously you will have your current go farther, right? So it will propagate through the tissues more. Just like with monopolar energy, as you change the tissue, as it desiccates and you get your effect, the impedance goes up in the tissue and you are less able to transmit the current through it. So you have to keep the kind of tissue you have in mind when you're using these devices. Obviously, something with a higher water content, it's going to be more effective. But as your effect goes on, the device itself will be less effective. So there's a physical constraint to the area that you get your effect. And as you can see in these pictures, the tip of your device and the tissue are both going to lead to how the tissue is affected. And so you really have to pay attention to where your lesion is and what kind of tissue it's in as how you select the appropriate device. And we'll talk about this in a minute, but nearby structures can also affect your field as well. Okay, so once again, we're taking current from the wall, putting it through a box, and what we're getting out is between 375 to 500 kilohertz. And as that alternating current is going through the tissues, we're getting the intracellular friction that causes heat. And the thing about radiofrequency ablation is we are now looking at large volumes of tissue, as opposed to that precise tissue effect that we want with our monopolar or our bipolar devices. The machines are pretty smart, and they understand that what you want to do is create coagulation of the tissue and denaturization of your proteins, but you don't want to skip ahead to vaporization, right? You don't want to blast your blood vessels and have them start to bleed within your cavity. So our goal is to keep an even, steady temperature. And the analogy is when you put a burger on your grill in the backyard, if it's up really, really high, what's going to happen? You're going to char and get a black burger on the outside, but when you cut into it, it's raw. You won't have had that heat effect on the inside of your hamburger. But if you turn the heat down a bit to, medium, high, with that slower, lower heat, you get more thorough penetration and cooking of your tissue. You get your medium burger all the way through. So we're trying to achieve that medium burger effect here, if that analogy works for you. We're also using a lot of energy. These devices can generate up to 250 watts. So it can require more than one dispersive pad to safely return the energy without burning the patient at the site of the pad. So that's why a lot of these devices come with more than one pad for the patient, sometimes up to 4, depending on what kind of an array you're using. Just like with using monopolar or bipolar energy, we have our frictional heating, we have that conductive heating effect. And you can see that there are different tines or active electrodes. And based on the size and the array of the tines, you can affect the size of your coagulation. So you choose that based on your target tissue. Some of the tips have cooling tips within them to try to keep, again, that from overheating right around the probe itself and getting that heat conducting back onto the tip. So again, just it's kind of an image of what happens when you rise rapidly around the tip that goes up really high. You have a more limited effect in terms of the distance versus your slow rise, controlling your impedance, allowing the heat, the low heat, to persist in the tissues until you get the coagulation effect that you're looking for and the desiccation effect. So these are a little tricky to use. I'd say one of the downsides of using the RFA is it just takes a long time. So to have this kind of long, slow effect, it can sometimes be 15, 20 minutes that you're standing there, and surgeons being the notoriously patient people that we are, you know, we want to hurry things along a little bit. So this is one of those cases where you just have to turn some music on, sit back, and you just let the machine do its thing. You know, maybe alternate scrubbing out with somebody. But you want to make sure that you're going in at a right angle with the skin. Obviously, you don't want this near the heart, touching anything metal in the patient. You really don't want to lean, especially if you're doing this laparoscopically where you're using indirect vision. You need to keep an eye on it. And sometimes you can, you know, use more than one, but you just have to watch, again, your return. So again, some of the pitfalls is you might have non-uniform or irregular effect. I didn't talk about the indications, but this is not your primary treatment, I would say, for a tumor. What we're looking at is patients who are palliative, who are unresectable because of location. Perhaps the tumor is directly adjacent to a vital or critical structure. Patients who have metastatic disease but might want some debulking. Somebody who's a poor operative candidate for open surgery. And sometimes this is a bridge to transplant for patients with liver tumors. So just we'll go through some pictures here, but you can see that when you have successful ablation, you get this liquefaction, essentially, of the tissues within the area. So you should expect that when you're doing your postoperative imaging. That is an adequate ablation. I alluded to this before, but one of the potential pitfalls of using the radiofrequency ablation is if your tumor or mass is adjacent to a large vessel. So what's in that large vessel? Something that has a lot of water in it, and current, as you know, wants to divert down and away through a tissue that's more conductive. So essentially you get this thermal sink as the current gets pulled down into the blood and sort of washed away, and it can limit the tissue effect near that vessel. So you're not getting true death of the cells, and unfortunately that can lead to things like recurrences near that vessel. So you can see here where the white arrows are next to those large veins, that you don't have the white tissue, the cell death in between them because the current was pulled away. And in the image, you can see how you can leave tumor burden behind at the periphery of your field. So again, an example of a recurrence adjacent to incomplete ablation. And it's frequently up close to those big vessels. There is always risk, of course. We're here to talk about potential injury and how to prevent those things from happening. You really want to keep this to a lesion that's 5 centimeters or less. Sometimes with larger lesions, people reposition the probes, but you want to be careful about that. Where it goes through the skin, you want to make sure there isn't heating of the probe itself. They're supposed to be cooled, but you have to keep an eye on it. There are a lot of structures inside of your organs, right? So in the liver especially, you can get bile injuries, you can get a hematoma, you can have injury nearby. One of the tricks with the RFA is that sometimes you can create an air pocket around the organ itself. So air is a good insulator to energy and current, and you can prevent diversion of the electricity to another organ that's not your intended target that way. But again, here's an example of somebody who had a hematoma and an abscess that actually had a patent vessel and needed to be coiled after an RFA. And here's an example of a patient who had a bile duct stricture and required an ERCP to stent that after an RFA. Okay, so we're gonna make this a little interactive since mine's pretty short. So I'm gonna pick on you guys by table and make you answer. So let's see, the table right here, you three guys right in front. Anybody wanna offer an answer to this question? What is the indication for RFA in a kidney? Anyone? Indication is it's metastatic. So. And I think the point is that it's, again, we use this not as primary, but as salvage technology. All right, next table, that table there, you guys. We're trying to reinforce what we went through. They say B, good job, it's 250 watts, excellent. All right. Which of the following statements regarding RFA versus electrosurgery is correct? Let's go to the back of the room, the very back table back there. Which one is right? Anybody? A? Good, excellent. But you guys were listening to me and you knew that you might have to have more than one dispersive pad due to the amount of energy that this technology generates. Okay, excellent. All right, let's see. You guys in the back close to our technicians in the back there. We've got a large blood vessel. Okay. Whoa. What just happened? Yes, C, right? That tissue sink, the blood is pulling the current away. You're not going to have the heating effect you want. Last one. Easy one. Everybody. So, tissue effect from 60 to 100 degrees. This is really important. What tissue effect are you getting at 60 to 100? B, yes, thank you. Coagulation, right? That's what we want. We want those proteins to denature, stick together, blood vessels to seal. We don't want the cells to explode, and we don't want carbon. Okay, we will very quickly talk about microwave ablation. So, microwave is not radiofrequency energy, right? So in radiofrequency energy, it is the current alternating that is going through the cells. In microwave, it has a much shorter wavelength than radiofrequency ablation. So we're looking here at wavelengths of less than 10 centimeters, very, very short and very high frequency, so 915 megahertz to 9.2 gigahertz. My brain cannot even handle that logarithmic increase. So very fast, very short, and the actual energy wave is being transmitted off the device, not current. So that leads to a very different tissue effect, which we call dielectric. And different kinds of tissue have different water in them and different effects. So here's our device. You can see the tip of it, the antenna, actually broadcasts that wave. So the wave of energy itself is going through the tissue. And what does that do? It affects the water molecules. So this is just like in your microwave at home. And the natural dipole effect, right? It's a charged molecule. They are rotating as that wave passes by, and the electromagnetic energy alters the field. And that fast rotation at those very high, megahertz and gigahertz rates is what is then causing the rotational and the frictional heating, as well as the water increasing in temperature. So this is a very reproducible effect. You don't have as much of an effect from impedance because this is not a radio frequency wave. But the antenna is what is affecting your field. So the shape of the antenna and how it's positioned will affect the shape of your tissue destruction. And there are different specialized antennae based on where your lesion is and what effect you want. So again, it can also have potential side effects. You can see the skin burn. We expect there to be liquefaction and cavitation, but you need to know when a patient just has liquefaction versus an abscess, right? A is probably not, B probably is, and if a patient has symptoms. Again, you can kind of see the tissue effects here. So, a few quick questions about microwave versus RFA. We haven't picked on that table over there. You guys on that side, behind Dr. Sharon. This is one of those my brain is confused questions, but you might see some of those if you take the fuse test. C, right? So the wavelength is much, much shorter. It's much higher frequency. Okay. I don't think I picked on that table back there. So you guys, when you're using microwave ablation, what kind of complications might you get? Yeah, so you can actually, because this is such a powerful effect, and you don't have the tissue sink like you do in RFA, you can get, in the liver, for example, a arterial portal fistula. Okay. What is a principle of microwave energy delivery? Did I hear D, hopefully? All right, so the dielectric is, it's the amount of water in the tissue. It is not impedance that is going to affect your tissue effect with microwave. And I think this is the last one. What is not a complication? Yes. that would be your anesthesiologist's fault, not yours. Oh, here we go. Okay, I think this is last. All right, comparing these RFA and microwave, which one's true? And of course, it's the last one, right? So the first one, it's flipped. RFA is a closed circuit, microwave is the antenna. They don't both use dispersive electrodes. There's no dispersive electrode in microwave because there's no current. And RFA is more affected by tissue impedance. All right. Thank you, guys.